If someone's got excruciating knee pain, you're going to have to do more imaging. Right. So I haven't done much in the way of MSK teaching in general these days, and definitely not on these collective mind lectures. Sorry, I don't know why my throat is getting so dry, red. Okay, so let's have a look. So we're having a look at this MRI scan. So this is sort of your more sort of T1 weighted image. And we're just having a look through. And at first, it doesn't feel like there's all that much going on, right? And what I'll do, I'll try and point out some anatomy for people that are not entirely, well tuned with MRIs of the knee. So first off, what you can see is this is the medial knee, right? I know it's a medial knee because of the shape. And for those that don't know, if you're playing golf, right? And you're going to play golf, you put the golf tee, the golf ball between your legs or on the outside of your legs. Hopefully, if you play any golf, it'll be between your legs, right? And the reason I say that is because this looks like a golf tee, and therefore, if it's between your legs, it's going to be the medial. So this is the medial medial tibia, and you go right across the other side, and then this one looks a bit like a rifle of a gun, right? So if I had a shotgun, I wouldn't keep it between my legs for obvious reasons. I keep it on the outside of my legs, and therefore, if it looks like a shotgun, like handle, then it's going to be the outside. That's one way that if someone just presents you with something like this and you're not sure, if it looks like a shotgun handle, it's going to be lateral, and if it looks like you're going to play golf, then it's going to be medial, right? And then you've got your menisci, and these are these sort of bow tie shaped things over here. And the medial meniscus, it should really be like this back end is bigger than the front end. And actually in this one, you can see that is probably true. Scrolling through, can we see anything grossly abnormal? Not massively abnormal there. And then can you see there's like a line here and then a second line over there? So that's anything between there is going to be your chondral surface. So the chondral surfaces, are they okay? Yeah, they actually look okay, don't they? They don't look too bad. So now when you come to the middle of the knee, you can see that you've got your ACL, which is this line like this. And that can get very, very thick, and sometimes it can get a bit edematous, and that's going to be called mucoid degeneration. It can happen over time. Nothing. It's like a normal thing that can happen over time. And this doesn't look like it's torn. So this looks very, very linear. And then as you kind of keep scrolling, because it's very, very black-like structure, and that's going to be a PCL, and that looks very, very normal as well. It looks like it's okay on this side. Now, if we come to the lateral meniscus, so come to the lateral meniscus, this is going to be like a proper bow tie, right? This should be pretty much equal on both sides. And actually, yes, this is true. It's actually equal on both sides. Doesn't look like there's anything grossly abnormal there either, right? Fine. So let's keep going. So don't worry, yeah, I mean, this is not an easy case. I mean, these are all good guesses that you've given so far. Right, so now what we do whenever we're looking at any MRIs is have a look at that patella. So the patella is sitting within the trochlear groove. Have I got the images there? Yeah. So the patella is sitting right within the trochlear groove. Can you see that? Right there, right? And so what happens is that trochlear groove is going to have a slightly longer and steeper side compared to a slightly more shallow side, right? And that's because the patella, if we're left to its own devices, would run away from you laterally. Like what I mean, run away laterally. And so therefore, if it's longer, that means that side is trying to keep the patella in, trying to make building that wall a lot bigger so that patella doesn't run away. And that's therefore going to be the lateral side of the ankle. Yeah. And the shorter side is going to be the medial side of the ankle. And therefore, if you do get a dislocation of the patella would go this way and then would come back again. But before coming back, it'll make a quick visit to that lateral femoral condyle and come back again. But this actually doesn't look like it's done that. There's no bruising on this side because that's what would actually impact over here, but that hasn't happened. And there's no bruising on this side either as well. So this actually looks like it's okay. Now, remember that chondral surface I was talking about? Now, this is a chondral surface like this. Remember, there's two lines. But actually, when you're coming up to this area, it starts to get a bit thin. And then you got a chondral surface again. And then you got a little bit of this edema sitting over here. So you got a bit of loss of chondral surface, a little bit of edema close to the patella apex on that sort of medial patella facet, right? Now, that's one bit of area of chondral loss that we definitely have. We'll come across to this one and just see if we've got any other chondral loss. So remember, we're talking about that V shape where that patella is sitting. Now we're looking at that valley, but from the side. And so now this is where it's useful. Are we lateral or medial? Well, we know we're lateral because of the shape here, but this looks like a shotgun. So therefore we're lateral. And actually, when you come up to this area, you can see that double line there, and it's kind of complete loss of that double line. It's gone. And then you've got no line there. So you've actually got what looks like a complete lack of chondral surface over here. So lack of chondral surface there, and actually looking closer, a little bit of bone marrow edema there as well. So loss of chondral surface involving the what looks like the lateral trochlear facet. Okay, so is that all that we're looking at? Actually, there's a little bit more to this. So someone said quadriceps. Let's have a look at that quadriceps. So that quadriceps is over here, going along like so, and it seems to be attached to that patella quite nicely. Then you got your patella tendon over here, and there's no inflammation over here and no inflammation over here. So that patella tendon looks okay. Can't be 100%. We do have to look at the axial views as well. So let's have a look at the axial views. So this is going to be the patella tendon coming up, coming up, coming up. That looks like it connects quite nicely, coming up, and that's the quadriceps tendon. So far, it looks like we haven't seen anything else that's particularly abnormal. Right. So now let's go to this area over here. So, I haven't shown you the ligaments. So let's have a look at some more ligaments before, and this will hopefully give us what we're looking for. So now we're looking straight on. So it's not a quadriceps tendon tear so far. So we have got so this is the medial aspect of the knee. And what you can see is the MCL, and you've got deep fibers and superficial fibers, and they actually look like they're okay. And you've got your LCL, which is this thing over here. And then you've got your bicep femoris and your iliotibial band that connects all the way to the fibular head, and they actually look okay as well. But what should really happen is that this MCL should go all the way down like so and should be very, very closely associated with the proximal tibia. But in this situation, there does feel like there's something else sitting here. Can you see that? That area over there looks kind of abnormal. There's something sitting, pushing the MCL out. It's not meniscal material that's pushing anything out. It doesn't look like, I mean, as you look at it now, you can see, yeah, there's all this kind of material that's pushing everything outwards. There's something very, very abnormal about that area there. So what is this? What's going on? So let's see if we can find this exact thing on the T1 weighted images. So and this is what I really like about this platform. I mean, this is literally an online, DICOM viewer, and this is why I use it for all my teaching, for my registrars and the courses that we run with radiology seminars. We always use this platform because it just seems to do such a good job for us. Right. So now when you come to here, see what that line is, see what that line, you can see this area over here doesn't look normal. There's some sort of weird sort of material sitting there, and it doesn't look like fluid. It doesn't look like fat. It just looks kind of ambiguous, but slightly isotense with the muscle and the fat in the this particular sequence, but hypo-intense on the more T1 weighted images, right? So what you've got is someone who's got quite significant pain and what looks like there's some sort of mass or some sort of lesions located deep to the MCL, pushing the MCL out. Now, the other thing that might give it away is that whatever this material is not within the actual joint. So it's actually extra-articular, isn't it? It's outside the joint. So extra-articular, peri-articular, someone might say. It's a peri-articular soft tissue lesion in a patient with a large joint pain. This is gout. So yeah, this is actually like a gouty tophus, and that's what's causing this person's pain. And what you probably need to do is recommend this person gets their urate levels checked and see whether they've got any other large joint involvement. So knees can be involved. Generally speaking, most people would say it's going to be the big toe. It's very, very common, very, very common finding. Someone who's got gout is going to have big toe problems. Can also happen in the elbow as well. Can happen in the C-spine as well, actually. But yeah, so this is like a gouty tophus, and what you may want to do if you're still unsure, take a biopsy, check the urate levels, and see what's going on there. But actually, everything else, it was biopsied. Oh, okay, there you go. So yeah, oh no, I think I read that. Anyway, yeah, so it was biopsied and proven as gout. So this is, I thought, a really interesting case because I've actually got something. Actually, I'm not going to say. I'll bring it up another day. But I do have a similar-ish case at some point in life to show you guys. Right. Let's have a look. Do I have any more? I think we have finished. We have finished. So thank you so much for everyone that has turned up, given me your time. Thank you so much for the donations, the cases. You genuinely don't understand how much I appreciate the donation of cases, because it just means that it means so much that you guys are getting value from it. And I really hope that, if you guys want to, you can get involved too, chat, talk, show me some interesting things, present cases if you want to. I really don't mind. I think the whole point is, if you're interested in radiology, hopefully you enjoy it. It's a bit of entertainment, a bit of enjoyment, and a bit of, getting to know each other and stuff like that. And feedback is so, so important for me, because if you don't know this by now, I really enjoy teaching and I want to be the best teacher that I can be. So if there's something I can prove, do let me know and I'll do the best I can to do it. Okay, so from me, thank you so much. I'm going to hand it across to my colleague. Thank you, everyone, and have a good evening. Bye.